Welcome, everybody, dear participants, to this first webinar. I would like to welcome you all on behalf of the team of Save the Children and the Royal Tropical Institute to this first webinar on assessing sexual violence responses to the needs of survivors in humanitarian settings. This first webinar is a webinar out of a series of 3. But before we start with the webinar, I would like to explain some technicalities with you for everybody's optimal participation. So there is translation services available in French and in Arabic. So you can select your language by using the interpretation button at the bottom of your screen in Zoom. When you have selected your language from the drop-down menu, then you also should select mute original audio if you do not want to hear the English narration in the background. If you are on an Android or Apple mobile device, please click on the 3 dots in your meeting controls, then select language interpretation. You can select English, French, or Arabic. So there are translation services available in French and Arabic. If you have any technical issues when you are participating during the webinar, you can please type your constraints in the chat box or directly to the co-host page or to Katie that can assist you in that situation. If you lose your connection, you shouldn't worry because you can rejoin still when you log in. That's no problem. You can be admitted anytime during this webinar. And we will also have recordings available after the webinar in the different languages in case you missed anything. We would also like to emphasize that to keep your sound muted during especially the presentation of the key findings of the research that we will be presenting. But after the presentation, there is space for questions and answers. And then if you have a question, you can unmute your microphone. But please keep it muted during the presentations. And if you have any questions or comments that you would like to raise, you can post them in the chats, also in the different languages, so the interpreters will help with translating. So you can raise and post your questions in the chat function. And some questions can maybe be answered already directly, and others we will collect and respond to at the end of the presentation. So once again, welcome to this first webinar. In 2018, Save the Children and the Royal Tropical Institute started a project called Research for Change, to assess the needs of survivors of sexual violence in humanitarian settings. This project included 3 countries, Haiti, Yemen, and Nigeria. But in the end, we were able to complete 2 studies, which are the studies in Nigeria and in the south of Yemen. And today we would like to share with you the main findings of the sexual violence study that has been conducted in Borno State with the financial and technical support of a committed team also from the European Civil Protection and Humanitarian Aid Operations, ECHO. And I will be your moderator today for this session. My name is Lindsay Kusters, and I work for the Royal Tropical Institute, KIT, in Amsterdam. I'm a senior advisor on sexual and reproductive health and rights, and have been engaged as one of the principal investigators as well throughout this Research for Change project. So once again, welcome to you all. let me introduce the program for today. So we will start with the introduction, or we have started already with that, to the webinar. But we will also like to know and have a better indication of who is with us, you as participants joining. So we will have a poll to fill out. Then we will continue with presenting the study findings. So what have been the methodology used, the findings, what are some of the good practices that came out of this study, and key recommendations. Then at 3:25, depending on the time zone you are, but this is the time zone in Amsterdam, we will have time for questions and answers. And to end as well this session at looking at how to give follow-up to these findings, because this research has been conducted on assessing the needs of sexual violence survivors, but what can we do as an international community with these findings, and how can be given follow-up to these gaps that we will also come up with in the findings of this study. Then around 4 o'clock, we will have some announcements left and we will close the webinar. So thank you all for joining. And yeah, we have a poll for you to see who is in the room with us. So Paige, could you start the poll?
No problem, just launched it.
Great, thank you. And Paige, can you present the outcome, because it's not visible for me?
Yes, it says I launched the poll, but it doesn't look like I have the capability to launch I don't have the results on my end.
I also don't see them. So sorry for this technical obstruction. I try to launch it again, and then hopefully it will work with the outcome as well. So please, can you fill it out again? Yes, I see people filling it in. Thank you. Yeah, so the majority, it looks like, of participants, you are from an NGO, non-governmental organization. And then like on an equal basis, there are participants like 12% from the government and also around 11% from research and knowledge institutes that joining. 7% are other, maybe as well independent consultants or yeah, working for other organizations. And we have also quite a number of students or like 4 that are joining in as well. That's great to see. A majority of persons is currently working on sexual and gender-based violence. Around 40 of the 59 respondents work on sexual and gender-based violence and related activities, and 19 of 59 respondents are not active currently on sexual and gender-based violence. We have quite almost half of the respondents, like 52%, are actually active in the context of Nigeria in your work, and 49%, so also almost half, is not. Looking at if you are a tea or a coffee person, tea is really our thing. So 1/3 of the respondents have a preference for tea, and 1/4 of respondents preference for coffee, 20% for both, and also 1/4 prefers water instead. So which continents are joining? It's the majority of 44% is from the African continent, based in the African continent, 14% from the Asian continent, 34% from Europe, and 8% from North America. So now we have a bit better idea of who is in the room with us. So thank you for filling out the poll. We continue with introducing the speakers of today. These are Diana Amangere, Tasneem Kakal, and Chitra Nagarayan. All 3 speakers have also been part of the research team to conduct the research on assessing the needs of sexual violence respondents.
Lindsay, I think you need to unmute.
Yes. So Diana Amangera is a global health expert currently working as a sexual and reproductive health and rights technical expert at Save the Children International. She has more than 10 years of experience supporting sexual and reproductive health programs and initiatives that promote demand and access to underserved groups and vulnerable populations in Africa. Tasneem is working for the Royal Tropical Institute in Amsterdam. She is a feminist youth advocate and researcher in development, currently working as the SRHR advisor. And she has experience conducting mixed method studies on SRHR, so sexual and reproductive health and rights, in various settings, and focuses on youth and sexuality. And our last speaker that I want to introduce is Chitra Nagarayan. She is a conflict and human rights researcher, practitioner, and activist. She focuses on conflict analysis, climate security, defending human rights, peace building, and protection of civilians. And she has been working for quite some time already in conflicted affected areas, which include northern Nigeria and the Lake Chad basin. So we're going to start with sharing the study findings from Borno State in Nigeria. So I would like to give the floor to Diana.
Thank you, Lindsay, for the introduction. I will take you through the background of the study. So this study took place in northeastern Nigeria, in Borno State. And why this particular? Why Borno State? So particularly, we know that Borno State has had a Boko Haram conflict since July 2009. When we look at statistics, we see that 8.5 million people are in need of life-saving assistance. We also see that 1.7 million of them affected women of reproductive age. Statistics also indicate that gender-based violence prevalence rate is at 30%, while sexual violence is at 16%. Next slide, please. This study set out to assess 4 objectives. The first objective was to look at how sexual violence in humanitarian settings affect people of different gender. The second objective was to look at someone is indicating that they cannot hear me. Lindsay, is that the case? Just checking. I've seen someone in the chat saying they can't hear me.
No, we can hear you well. So it has something to do with the participant itself. So maybe that person has to rejoin again.
Okay, I will proceed then. The second objective was to assess what medical and psychosocial services or assistance survivors have access to, and identify gaps, but also with a reflection on how this actually relates to the different gender, with an element in gender. Our third objective, we wanted to look at whether there is compliance with or whether programs or interventions actually are aligned to international standards in medical and psychosocial services or international World Health Organization protocols or international humanitarian law, and how also they are integrating international human rights law. So we also wanted particularly to look at that. Our fourth objective was to look at to assess which good practices exist in the context of Nigeria, and then see which ones can be reproduced either in the Nigeria setting or within similar settings like Nigeria, particularly the Borno State that we focused on for this study. Next slide, please. Speaking of the methodology, so how we conducted this research, we adapted mixed methods. We mainly looked at, we used in-depth interviews, we used focus group discussions. These two were applied on survivors and non-survivors, who are mainly women, like we will see on who participated. Key informant interviews with either government officials or service providers in this area within the Borno State. And we also conducted health facility assessments. So who did we apply this to? We did, we made sure that there was diversity in a way we sampled our participants to ensure that women of different age groups participated, including the young and the old groups. We also included those that are in IDPs, which are internally displaced persons participating, and also host community. We ensured that we involved women with disability, and also ensured that survivors of sexual violence were also involved in the study, to make sure that there is a diversity in the responses that we got. We also had, like I said, we did have interviews with service providers who were already practicing in this area, have been providing services to survivors in this area. We also interacted with government officials. We did health facility assessments with six facilities, 3 that are NGO supported and 3 that are government supported. Where did this study take place? This study took place in 2 local government authorities, Damboa, Gonza, and Njeri, but we also did data collection at state level. In terms of analysis, we generated both qualitative and quantitative data through this research. And with the qualitative data, we used thematic content analysis to draw meaning through the raw data. And also we generated descriptive statistics such as tables and percentages, using tables, percentages to represent the descriptive, the quantitative data. We adapted some frameworks, for example, the ecological model, to ground our research findings. Throughout this research, we also adapted certain principles like conflict sensitivity, social inclusion, and also the principle of doing more good than doing no harm as we were conducting this research. We faced certain limitations, and these limitations were mainly to do with accessing the areas of study due to issues related to security that led to restrictions to access certain areas. So that's why you see this study is in particular LDAs or local government authorities. We also had, we were limited to explore certain dynamics, for example, female genital mutilation and circumcision broadly within this study because of the areas that actually we focused on for that study. In terms of ethical approval, we got ethical approval from the Peace Research Ethical Board, and also got approval from the State Ethical Research Committee, Ministry of Health of Nigeria. At this point, I would like to hand over back to Lindsay to introduce the next speaker. Thanks so much for your time.
Yes, thank you, Diana. So I would like to ask Chitra to continue. I would also like to emphasize that in the findings, it will also contain information about sexual assault, gender-based violence, and other forms of violence, which can be emotionally triggering to some individuals. So I think you should be aware of that as well. Over to you, Chitra.
Thank you very much, Lindsay, and good morning, good afternoon, good evening to all of you, wherever in the world that you may be. I'll be talking about the dynamics of sexual violence in Borno State. Lindsay, if you can click over to the next slide, please. Yes, thank you. So on this slide here, you will see a number of different forms of sexual violence, roughly in the order of the extent to which they were spoken about. Now, of course, this does not necessarily reflect their incidence, their relative incidence. What it does reflect is rather which forms of sexual violence are spoken about and which are not. And I'm going to concentrate here on the 5 most commonly discussed forms of sexual violence in our research. There are other forms taking place in Borno State, specifically FGMC, forced abortion, and denial of abortion. Denial of abortion will be dealt with when we come to talk about service provision. When it comes to FGMC, I would like to just state here for your reference that Northeast Nigeria sees some of the lowest levels of female genital mutilation and cutting in the country. However, this is very under-researched. It tends to take place in one particular community in Northeast Nigeria, in Borno State, and is an avenue for future investigation and research, and indeed programmatic intervention. Now, going on to sexual exploitation and sexual harassment. Sexual exploitation, when we conducted the interviews, was the first form of sexual violence mentioned by many participants. Of course, that doesn't, as I mentioned before, necessarily denote that it is the most common type of sexual violence, just that it's the type of sexual violence that people feel most comfortable discussing openly and see as most visible. In a conflict-affected environment such as Borno State, of course, the lines between sexual exploitation, sex work, survival sex, transactional sex are blurred and linked to the general economic and security situation of women and girls, particularly those who have lesser access to resources and to social networks. Women and girls living in situations of financial precarity, who have lack of livelihood options, often have very little choice but to exchange sex for money, food, shelter, protection, and humanitarian assistance. We found particularly high levels of sexual exploitation amongst adolescent girls and women and girls with disabilities and people whose families were struggling financially. Several participants said that perpetrators tended to be men with higher relative wealth and power, including those who had power over humanitarian distribution, soldiers and other security agents in particular, and that this incidence was heightened due to lack of livelihood options, erratic, diverted, and sporadic humanitarian assistance, and linked to other forms of potential violence, as I'll go on to discuss later on. In terms of sexual harassment, this was viewed as widespread, particularly for adolescent girls and young women, often not reported, sometimes normalized. And although it was normalized for the young women with whom I spoke, this really affected their lives. It affected mobility, where they could go. It affected access to education, access to healthcare. And they talked about how, even though this form of sexual violence, this sexual harassment, especially street sexual harassment, had been prevalent prior to the conflict, that it had increased as a result of conflict dynamics, and particularly people having fewer livelihood options, men having fewer livelihood options and spending more time gathering in groups, which in Borno State are called majalisa, which is when people sit together under a tree or some form of shade to pass the time in conversation. And this was a site of gossip and sexual harassment. Moving on to rape and sexual assault, people spoke about how women and girls across age, disability, ethno-linguistic, religious backgrounds, geographical locations, marital status, were subjected to this form of violence. They talked about the intersectional nature of this violence, particularly for women and girls with disabilities, women and girls who were displaced and or engaged in sex work. Now, in Borno State, the idea of marital rape is a bit, shall we say, controversial or not accepted. And so we tended to talk about forced sex within marriage. And many of the women spoke about how this was prevalent and how this had increased. And that's actually also borne out by the GBV IMS data, which records levels of intimate partner abuse. And this kind of sexual violence is taking place within marital relationships, but also outside. And so many participants spoke about how boyfriends could lure their girlfriends into secluded places and engage in rape and sexual assaults, with the girl in question often not even being able to report that because of shame. This word kunya, which is on the slide, is kind of a mixture of shyness and shame and embarrassment in the Hausa language. And it's one of the biggest barriers to reporting and help seeking in the context. The third form of sexual violence that came out was early and forced marriage. Now, the picture around this and how this was being affected by conflict really varied across our different research locations. In some places, people talked about how early and forced marriage levels had fallen as a result of sensitization and increased educational opportunities due to the interventions of local organizations, international NGOs, and UN agencies. In other places where there was less intervention, people talked about how levels of early and forced marriage had increased and that parents had often very little choice to marry off their daughters at ages even younger than they would have otherwise. We also saw dynamics around bride price paying into this. So the levels of bride price have fallen because of general levels of poverty. And in addition to early and forced marriage, we see levels of early divorce. So girls being married perhaps at the age of 12 or 13, and then divorced at the age of 14 and 15, with one of the primary reasons for this being men's inability to provide for their families. And so rather than suffer the shame of not being able to provide for their wives and children, they often divorce them and they're sent back to their parents' house, who then have more responsibilities to take care of them. The next type of sexual violence that I want to discuss is abductions by armed opposition groups. Now, I'm sure this is probably the type of sexual violence those of you on the call know about the most because of the worldwide attention paid to this form of violence in the aftermath of the abduction of almost 300 girls from Chibok Girls Secondary School, almost exactly now, I think 8 years ago in 2014. These abductions were just some of thousands of women and girls who have been taken over the past decade, and these abductions are still continuing. Often the dynamics of security in Borno State are that you have military presence surrounded by a perimeter of land, which is more or less safe. But then often people have to go beyond this perimeter to fetch firewood or to engage in farming. And that is where you have presence of armed opposition groups who take that opportunity to abduct women and girls. And often you also have the dynamic of women and girls being sent out to engage in these livelihood activities to safeguard men and boys who are seen as more likely to be killed. And of course, we know that once women and girls are abducted, they're forced into marriage, sexually enslaved, and face very high levels of sexual violence. And the last area or type of sexual violence that I'd like to talk about is denial of the right to use contraceptives. And this came out very strongly amongst participants who are married, who spoke at length about their struggles to maintain control over their reproductive lives in the face of their husband's hostility to family planning. This reluctance to use contraceptives is long-standing in Borno State and indeed many parts of northern Nigeria. There's this idea that the more children that you have, the more wealth you have. There are ideals around masculinity. So the more children you have, the more of a man you have. There's a preference for sons. And also, and this is the link with the conflict here, there's this idea that we need to replace the people who have been killed during this conflict. And we see all of that kind of playing into denial of contraceptives, or if husbands find out that their wives have been accessing contraceptives, often there are cases of that leads to marital discord, and in some cases intimate partner violence, and in some cases divorce. And let me just note here that perpetrators of sexual violence span a range of backgrounds. They can include family members, including husbands, armed actors, so members of armed opposition groups, members of community militias, and also members of the security forces, particularly soldiers when it comes to sexual exploitation. They can include neighbors, people in the community, and people also linked to humanitarian activities. Next slide, please, Lindsay. And I am going to read you a couple of testimonies here that I hope really highlight the dynamics. And in this one, you can see the link between abductions, or the risk of abductions, and sexual exploitation. And this woman told me, if I stop my girl from going to the farms, harvesting crops, and I should just mention here as background, there have been a couple of cases where her daughter was chased away from these areas, either by soldiers or by members of armed opposition groups. So obviously her daughter is experiencing significant risk by engaging in this livelihood activity. But whenever this woman tries to stop her daughter doing so, she says, if I stop, who will assist us? And you only have one hand, so no one will hire you. And so she insists and goes. And the woman went on to say, as a result of this, I had to start doing what I did not want to do. I did what is not expected of me as a mother to support myself and my children. The man did not force me into it, but I willingly accepted in exchange for the food he would provide, then became pregnant. And I have a second testimony that I would like to share with you, just showing the normalization of sexual harassment and the idea that this is seen as normal and minimized since they did not rape me, and therefore it's not worth reporting, and it's only when you talk with girls and young women that they mentioned what is happening to them. Next slide, please. And I would just like to end my portion of the presentation by just highlighting some of the consequences of sexual violence. Firstly, to survivors, they face consequences when it comes to their psychological health, their physical health, their psychological well-being, experiencing kunya, or this shame and embarrassment and shyness. They're stigmatized, their marital prospects are affected. And also we found that if you've experienced one form of sexual violence, you're more likely to experience another, or sometimes that you're subjected to one form of sexual violence because it's thought that that will reduce your risk of another. For example, parents marrying their daughters at young ages to reduce the risk that they will be sexually exploited. For families, families engage in a lot of self-blame and recrimination, particularly of mothers who are seen as responsible for the safety and the moral upbringing of their children. They experience shame and loss of community respect. We also found that sexual violence affects all women and girls in terms of levels of fear and associated restricted movement and limited social interactions. The risk of sexual violence also impacts their access to education, income, and livelihood opportunities. And in some cases where it's known that a case of sexual violence has taken place in a particular community, there can be stigmatization, not just of the survivor and her family, but indeed all women and girls in that community. And then finally, when it comes to perpetrators, there is a lesser likelihood of the perpetrators facing consequences. The consequences across the board, participants said that the consequences tended to fall mostly on those who survived rather than perpetrated violence. but that this was changing to some extent. And in some cases, we were seeing investigation and punishment through the judicial process, but also shunning by the community, particularly in cases of child sexual abuse, and where the perpetrator had less power. So it was unlikely that men with wealth and influence or soldiers were being held accountable, but you did see some level of consequences for men who are not in these positions of power and authority. And with that, I'll hand over back to Lindsay to introduce the next presenter.
I can just start. So thanks, Chitra, for setting the scene a bit. So I'm going to talk a little bit about the types of services provided. We had an insight about the service provision. Here is someone. Great, thanks. Paige, can you help me out here?
Yes.
Thanks. Thank you. Sorry for that, everyone. So this is sort of the second part of the presentation, and we got an insight about the types of services provided through the health facility assessment that we conducted, where we surveyed 6 health facilities run both by the governments or public health facilities, but also those run by NGOs or supported by not-for-profits. What we found was that medical services were the most widely available, and many of the facilities and also participants that we interviewed, many of the women spoke about the presence of counseling and case management. We saw that there was a sort of, most participants also spoke about the need for legal services, and this came also from the key informants that we spoke to, whereas there were legal services present, but they were not necessarily accessible because they were very bureaucratic in nature, or that it was just not easily accessible in terms of distances. And services around food provision, shelter, and livelihoods were also considered urgent by many of the service providers. These were also the types of services that were most widely in demand, particularly that around food provision, shelter, and livelihoods, simply because most of the survivors who the service providers would talk to, but also most of the survivors that we spoke to spoke about really focusing on their own basic needs, so fulfilling those needs as opposed to necessarily seeking out help from a legal aspect or from a medical aspect. So they were really concerned with basic food provision for themselves, particularly in the context of poverty, and also in depending on their status as a displaced person or not. We saw that across the board, services and protocols for survivors who were abducted were the most developed and standardized. And I think Chitra also mentioned that, you know, the sexual violence perpetrated by armed opposition groups is the most well known. Similarly, because of the international attention, also on this issue led to the fact that there were very clear protocols laid out for those survivors that were rescued, for example. And this clarity was not only present from the perspective of the providers, but also from many of the women themselves, whether they were survivors or not. Many of the respondents that we spoke to in the community had knowledge about what to do when an abduction had taken place, or when a survivor was rescued. Similarly, what we found that although there perhaps was a gap in terms of the formal health services provided, there were quite some community structures and support that had emerged through the last couple of years. So we had examples such as Aunties Against GBV, a group of women rallying and supporting survivors, often women survivors, as Chitra already explained. Women leaders were considered quite important to be able to approach, to go to for help, and the Bulama, the community leader as well. Much of the work also focused on destigmatization of sexual violence when it came to survivors. So there was quite some, while there was a fair amount of stigmatization of abductees, but also survivors of sexual violence, primarily of rape, and let's say those forms of violence are considered more severe, quote unquote, by the community. Because of that, there was a lot of response by government and non-governmental providers on destigmatization, primarily through community engagement, announcements, campaigning, but also awareness raising sessions, for example, with adolescents, creating safe spaces for them to come and talk about this. As I explained, there were some safe spaces, but there was also a call, and we will get into that a little bit more in the recommendations, which is the third part of this presentation, about the need for safe spaces and what those could look like. In general, as I said, a lot of the sexual violence work was also reactive. So it was in response to, let's say, stigma, or in response to abductees, whereas the work around prevention was, let's say, was more limited. So particularly around engagement of men and boys, sort of bringing them into the conversation, talking about gender and social norms around sexual violence is still, there still needs to be work that needs to be done there. Can we go to the next slide, please? I'm going to quickly scan through some of the challenges that were mentioned by many of the survivors that we spoke to, but also women in general. Some of these challenges were also highlighted by service providers themselves. So I'm going to talk about availability of services, accessibility, the fear of reporting, which makes service provision challenging, the capacity and attitudes of service providers, and finally, the inconsistent integration of sexual and gender-based violence programming in humanitarian and development efforts. So when it comes to availability of services, I already discussed a little bit with you that there was, while there were some legal services, the spread or the availability of these services could be improved. Many of the health facilities in also from the health facility assessment said that there were cases and situations where there was a lack of equipment or a lack of funding, which did not allow them to invest in necessary equipment to provide sexual violence related services. And because of the phasing out of humanitarian assistance, some of the services were also closing down. And we're going to talk about that later when we talk about recommendations as well. In terms of accessibility, as many of us know, the region does see a lot of insecurity time and again, which prevents people from safely accessing these services. Also because many of them are at, many women also reported to having walk distances, which made it difficult. Some of the services also had user fees, not necessarily those related to sexual violence, but this was brought up as an issue from the health facility assessment. And since we did focus on women with disabilities and how they experience accessing services as sexual violence survivors, we also saw that there were not many infrastructural there was not a lot of infrastructure for people with disabilities to access these services, but this was also, some of these challenges were also related to the capacity of service providers. In general, as I mentioned, there were high levels of stigmatization by the community, but also by women themselves. Peer pressure dictated that it was not important to report, especially if it was not a serious case of sexual violence, quote unquote, because of the wide-ranging normalization that was present, which Chitra already mentioned. Some of this also relates to, as I mentioned, the attitudes of service providers, where they would not take women seriously, which sort of reinforces the idea that sexual violence is normal. Some participants also reported poor communication from their side, a lack of sensitivity when it comes to working with people with disabilities, and key informants also indicated that more training around psychosocial counseling was needed with regards to sexual violence. Lastly, we saw that because of the withdrawal of aid and some humanitarian efforts, participants and key informants actually reported a perceived increase in sexual violence because of that, because of fewer services, because of fewer sensitization. There were, you saw the consequences because there were limited food distribution activities, limited economic empowerment activities. And in terms of inclusiveness, there were also issues in terms of who gets included on the lists in the IDP camps. For example, at times we found that female-headed households were not included. Can we go next, please? In terms of, I think we've kind of covered what was encouraging survivors to access services and what wasn't. And this sort of gives you a sort of a broader picture in terms of the kunya being a deterrent, but outreach by providers encouraging people to access services. You can go next. We just wanted to highlight some key findings from the health facility assessment, and then we move to the recommendations. I think we saw that many facilities rated poorly when it came to following international guidelines on sexual violence, but also having provision for people with disabilities. They definitely rated better in terms of documenting referrals, having more protocols on privacy and confidentiality. So we see, let's say, some positives to celebrate in that sense. We can go next. I'm going to hand over to Diana directly, so please go forward.
Thanks, Tasneem. Next slide, please. I'm going to be particularly speaking to the good practices that we identified throughout this research, particularly highlighting these three. And it doesn't mean that they are the only ones that are actually good practices within the Nigeria setting or the Borno setting with sexual violence work, but these are the ones that we picked that were sort of predominant throughout the findings that we gathered. So the first one is the use of a hotline to provide immediate support to survivors in the absence of health workers, or where they have the inability to access health services, whether it's due to distance, whether it is due to the cost of care, or where we have actually some marginalized groups that don't feel safe or don't find it comfortable to visit health facilities. So they indicated that hotlines are actually a good platform for them to be able to get immediate support for services. The second good practice that we identified was the provision of safe spaces in health facilities to improve confidentiality and privacy for survivors. And we see this in line with documented best practices for reaching underserved populations like adolescents or sex workers or even LGBTs, where you create safe spaces where people actually feel comfortable to come and access information or access services, which is very encouraging. Lastly is the use of community structures such as community leaders that we saw referred to as the bulamas, and then women groups and women leaders that provide support to survivors, either giving them immediate counseling or directing them to where they can get support, or escorting them to actually get support, or actually being there for them as a follow-up mechanism after they've received support, to make sure that they fit into society, or that they are dealing with a draining social norms, to make sure that they can resume they can go on with their life, or they can actually follow through the service pathway. So these are the ones that we highlighted as predominant. But as you interact with entire research report or findings, I'm sure you will highlight, you'll find some other intriguing good practices. Over to, I'll hand over directly to Chitra to speak to the recommendations. Over to you, Chitra.
Thank you very much, Diana. And we clustered our recommendations into 4 groups. Firstly, what we can do to improve service provision. Secondly, to counter stigma, victim blaming, and encourage help seeking. Thirdly, to better integrate sexual violence into humanitarian development and peace building. And then finally, building the knowledge base for evidence-based programming. And so I'll go through each of these in detail, starting with better service provision. So under this, we recommend the update, documentation, and socializing of referral pathways to facilitate multi-sectoral collaboration and improve survivor follow-up. This is already being done, but we recommend that this process be continued and made even more effective. Secondly, improve the inclusion of marginalized groups, and in particular, people with disabilities, adolescents, female-headed households, male survivors, and to do this through outreach to these populations, making services more accessible to them, and building the capacity of service providers. Thirdly, supporting health facilities to adapt and embed global standards and practices on service provision and retraining health workers. So really keying in to the health sector, because what we're seeing at present is a lot of great services are being provided, but there's a need to strengthen the Borno State health system more, and particularly at the primary healthcare level. And then finally, in exploring accountability mechanism for perpetrators, for example, through community censure and transformative justice approaches. I'll go on now to the next set of recommendations. Lindsay, if you could, thank you. And this is really looking at countering stigma and victim blaming, as these are forms of violence in and of themselves, plus also the greatest barrier, according to our respondents, to help seeking amongst survivors. So here we recommend the funding of women's rights groups, particularly those who work with marginalized women, to do sustained community engagement for prevention and stigma reduction, the raising of awareness of all types of sexual violence, including those in particular that are less visible, such as intimate partner violence and sexual harassment. And then finally, changing social norms and using peer-to-peer approaches. So for example, amongst adolescent girls, men who attend majalisa, which are these assemblies, which I spoke about earlier, or grandmothers, and also approaches that are intergenerational and take place within families. The third set of recommendations that we have is really in response to the urgent need to integrate sexual violence into the humanitarian development and peace building sectors. We found still in this was 2021 when we carried out our research, but there were times that certain actions were being flagged as increasing the risk of sexual violence, and still sectors not integrating this sufficiently into their planning and action. And in response to that, we recommend that there be real efforts to better integrate analyses around sexual and gender-based violence, as well as response and prevention in other sector strategies, and to continue the training that is already being done by the GBV sector to people of other sectors, with a particular focus on food distribution modalities, because we found that this really increased the risks of sexual exploitation in particular. And then secondly, expanding women's access to economic empowerment and livelihoods programming to counter sexual exploitation, and working and for the food and livelihood sectors to really focus on this, particularly in areas where there is planned withdrawal of humanitarian assistance. And then moving on, this is the final set of recommendations, and this is really stressing the need for evidence-based programming through strengthening the knowledge base, particularly on prevention, which we found to be a gap in terms of what people are doing. And so here, given that there has been some success in terms of challenging the stigmatization of survivors of abduction, in this context, to learn from these experiences, to inform anti-stigma programming for other types of sexual violence, to fill existing knowledge gaps, for example, on female genital mutilation and cutting, forced and unsafe abortion, as well as realities for people who are LGBTQI. So that's lesbian, gay, bisexual, trans, queer, and intersex. And then finally, to establish a community of practice coordinated by the protection sector with input from its GBV and child protection subsector working groups across different organizations working in different sectors, so there is a program of developing, socializing, and learning from this evidence. And we see a link between this knowledge base that is being built and programming. And I will end there and hand back over to Lindsay to facilitate our discussion. Thank you.
Thank you, Shritra, Tasneem, and Diana for presenting the main findings, the methodology, the good practices, and the recommendations that come out of this study. And with this evidence that has been produced, the aim is, of course, to improve programming on sexual violence and to have better responses and mitigation strategies to address the different types of sexual violence. So we would like to give the floor to the audience, the participants, to raise your questions in relation to the research. I don't know if people have included already questions in the chat that we can give or provide answers to. I see a hand raised. Yes, so if you have a question, you can raise your hand and we can take some questions and then provide responses to it. So I would like to give the floor to Nancy Ibrahim. If you can also introduce yourself, that would be good.
Hi, thank you so much for this amazing presentation. And I was wondering if you made this seems very easy. I was wondering about the challenges that you face to do such a sensitive study in this context and how you mitigate such challenges.
Shall we take some questions and then provide answers to that? So what are the challenges faced in conducting this study in Borno State is the first question. Are there other questions from the audience? I don't see any questions yet, but I think they will come. Oh, there I see hands raised. Yes, Dankat, Bentu, you can come in. And after
All right,
Rachel,
so
welcome.
all right, very, very nice presentation. My name is Bentu. I just wanted to raise the question about filling the knowledge gap, particularly, with respect to culture and the legality of such issues in Nigeria, and then the culture, particularly in Maiduguri. So how do we really go about that? Because it's a very, very sensitive sensitive topic, which I actually like the way it was presented in the presentation. Thank you.
Okay, thank you, Dankat. Rachel? And can
Good
you
afternoon.
introduce yourself? Thank you.
Good afternoon. My name is Rachel Hammonds, and I work with the London School of Hygiene and Tropical Medicine on law and global health policy. And I'm joining here today because I'm particularly interested in human rights and humanitarian law, and this confluence that we see for survivors of sexual violence being able to access their full range of sexual and reproductive health and rights. And that includes access to safe abortion care. So I'm in particular interested in understanding whether you have any data on obstacles, first of all, to receiving such care. As we heard before, there may have been legal obstacles, but if we're talking about a humanitarian crisis, access to safe abortion is recognized under humanitarian law as a right that survivors of sexual violence have. The second thing that I'm interested in knowing is whether you have noticed in your research any obstacles to funding such services from different providers. We know that the global gag rule has ended with the end of the last presidency. The new American president repealed that, so the US can now fund such things. But I wondered if you find this from other funding organizations that put a fence around providing such services. Thank you.
Okay, thank you. So we have 3 questions, starting with the challenges. Who would like to respond to that? So the challenges in the implementation of the research for data collection.
Chitra?
Yes, maybe I can start with that. I mean, in terms of the challenges were not just to do with talking the subject matter of this research, but also the security context of Borno State in Northeast Nigeria. And so unfortunately, there were certain parts of the state, including those where there were certain types of sexual violence, female genital mutilation and cutting, for example, were more prevalent, that we were not able to go to for reasons of security. Also certain types of perpetrators that it was more difficult to get information about. I mean, for obvious reasons, there is some level of fear when it comes to talking about perpetrators who are government actors and military actors in particular. There are certain types of sexual violence that are not discussed or framed as sexual violence, including rape within marriage, but also denial of contraceptives. And that is not really thought of as a form of sexual violence. And so we had to be careful about how we approach such topics and the questions and the words and the phrases that we used, which is why, as I said earlier, when conducting these interviews, I never asked about marital rape. We also always talked about forced sex within marriage. And then finally, I want to also raise the issue of secondary trauma to researchers, and especially given the unfortunately high incidence of sexual violence amongst the population. When conducting this type of research, you should just assume that at least some of your research team are survivors, and put in place strategies to encourage self and collective care in the collection of this research, of this data as well, because some of the things some of the conversations and the interviews that we were having were very distressing, even though we hadn't asked respondents to talk about their own experiences. Many of them did so naturally, and in fact said that they wanted to talk about what happened to them. We were hearing very high levels of victim blaming and rape myths, which can also be distressing to researchers. So Nancy, if you're planning on doing something like this in the future, I would strongly recommend that you think about what you can put in place to support your colleagues. I also want to answer Rachel's question on safe abortion, and then maybe hand over to Tasneem and Diana if they have anything that they want to say. So in Nigeria, there is a problem with access to safe abortion. And the problem is that abortion is criminalized under Nigerian law, except to protect the life of the mother. And as a result, unsafe abortion is one of the leading causes of maternal mortality in the country. But at the same time, for obvious reasons, we have very little data on this issue. Even though in the context of the conflict in Northeast Nigeria, we see levels of sexual violence increasing, levels of sex outside marriage, either premarital sex, or maybe a woman has had her husband detained by the military for years and started a new relationship. Despite this dynamic, we see stigmatization of pregnancies that take place outside the marital relationship. And also we see people, families, women talking about how they're struggling to take care of the children that they have themselves. And this was some of the things that came up when we talked about denial of access to contraceptives. Despite all of this, very, very few humanitarian agencies are looking at safe abortion provision. Those who do so understandably under the ambit of Nigerian law. And there is some evidence, as I said, there isn't much data on this, but when I spoke with health workers for another project, they told me about how the numbers of people coming to the health facility for post-abortion care had increased, in some places doubled, in some places increased 5 times, and that this was just the tip of the iceberg. And in the views of these health workers, that more women and girls were dying from unsafe abortion. But yet, as I mentioned, this is not really an issue that is discussed. And even within the GBV space in Nigeria, in Northeast Nigeria, this is not an issue that is much discussed. Even though, of course, in practice, there are people facilitating access to abortion. And in fact, abortion is provided even in health facilities for women and girls who have the money to pay. So really, this criminalization of abortion only affects those who live in rural areas and or do not have access to resources. So Rachel, I hope that answered your question. And in terms of obstacles to funding, I would say that, yes, the global gag rule was definitely an obstacle to funding, and many people who I've spoken to told me about this. But also I think organizations are wary of working on this issue given the law, but also what they perceive as the reaction of communities and the government if they look at this issue. Although if you actually talk to people in communities, they have a much wider range and diversity of views around abortion than perhaps some people working for these humanitarian agencies think. Let me stop there and hand over to Tasneem and Diana if they want to add anything.
Maybe I can address the question around sexual violence and child marriage. So from the study, we did see actually that much of the sexual violence programming that was done actually did center around child marriage, and there was a lot of sensitization around the disadvantages of child marriage, which is also why health or service providers and key informants did talk about the decrease in child marriage. Oh, let me put on my video actually. Sorry, did talk about the decrease in child marriage. So we see that child marriage is sort of receives, let's say, the attention as opposed to maybe other forms of sexual violence. And in the context of a child marriage or in marriage itself, I think Chitra already outlined some of the dynamics around denial of access to contraceptives and this idea that the men that have been lost in the conflict need to be replaced, and women do need to then reproduce. So I think it plays out in that way within, let's say, child marriage. But we did not necessarily dive deep specifically into child marriage in the study. So we covered a wide range of types of sexual violence. I hope that answers your question.
Thanks, Tasneem. Diane, would you like to come in maybe on this sexual violence being a sensitive topic and how to address as well the sensitivity through social norm change? There have been also a question about addressing the issue of LGBTI, so lesbian, gay, bisexual, transgender, queer and intersex people as survivors. And also the sensitivity of the topic during focus group discussion. So in general, there are kind of three people that have questions around the sensitivity of the topic and how we deal with it, but also in future programming, how to address, for instance, the stigma around sexual violence and the victim blaming that is also occurring. Diana, would you like to come in on that?
I would speak more on the stigma element, and then I will refer to Chitra to speak on the approaches for engaging the, I think was community leaders on LGBT issues. I think she's done this with another research. With this particular research, we did not focus on the LGBT group, but I know that there is research that we have looked at in the desk reviews that actually focuses on this work. So with that particular piece, I will refer to Chitra. But on the element of the social norms, in terms of the approaches that can be adapted, is that right, Lindsay, for future programming?
Yes, or can be used for future programming, because we also have one recommendation around social norm change. And I think there are some questions related to that that came from Dankat about the sensitivity and how to deal with social norms to address, for instance, the stigma. So more programmatic perspective on that.
Okay, yeah, from the programmatic perspective, I think what we see is first of all, like we talked about the adaptation of the ecological model to make sure that we are mapping out actually these pathways or the constraints along the pathway for survivors, where the norms really sit, whether they are at individual level, at community level, at institutional level, to be able to plug in interventions well. But particularly also what we saw was, for example, we see that where you do, for example, at individual level, from the programmatic perspective, where you do peer-to-peer approaches in terms of opening dialogues within peers, whether you're doing it within adolescent groups or you're doing it within homogeneous peers like women groups, to be able to speak up. but particularly also we see where you get an intergenerational, open for the intergenerational dialogues, where you get, for example, the bulamas and you get adolescents, so women start to interrogate certain issues that they're uncomfortable with, or where you promote family communication to be able to start to speak about particular issues as some of the ways to actually move a point on addressing social stigma. I don't know if I'm addressing your question well, but I would say that it is important when we talk about social norms. It is important to map out actually to look at the person from a holistic perspective and begin to map out those areas using the ecological model. To know what constraints sit at individual level, what constraints sit at family level or institutional level or policy level, and articulate sort of like aligned programming to address those elements, because the four components do intersect. In terms of the question on LGBT, because we didn't explore this from a research perspective, we didn't explore this within this study. I will refer to Chitra, but happy to build in if we are looking at a service delivery perspective for LGBT people. Chitra, over to you, if you can bail me out.
Yes, no problem.
Thank you.
So the question, I think, was what methods you can use to engage with traditional leaders on LGBT issues. Is that correct?
Yes, that's correct.
I mean, I think in the context of Northeast Nigeria, there is such a high level of discrimination against LGBT people that I wouldn't necessarily start with engaging community leaders. Also, please remember that the certain forms of behavior, and in the words of the law, public displays of same-sex affection are criminalized in Nigeria with a 14-year jail term. And the registration operation of clubs and societies that promote gay rights are also criminalized. So rather than starting with engaging community leaders directly, I would start by talking to people who are LGBTQI themselves about their needs, including around access to humanitarian services, including around sexual violence service provision. As Diana mentioned, this was not a focus of this particular research, but I have done other research on this area, which shows that LGBTQI people face severe barriers accessing humanitarian assistance because of their sexual orientation and gender identity and expression, that this is not an issue that is even acknowledged by many humanitarian actors, that people experience high levels of sexual violence, but because the perpetrator is of the same gender as them, they're unable to report due to fears of criminalization and stigmatization. And again, this is something that that humanitarian sexual violence service providers need to take into account and see how to increase outreach to this group and also make services accessible and comfortable to them without judgment. And maybe I can end there.
Okay, thank you, Chitra. Are there any other questions? Can you raise your hands? Then we have like 2 questions more we can take on. Who would like to come in? Feel free. If there are no questions, then it would also be good to hear from the research team how direct follow-up has been given. So some validation sessions have been held with the stakeholders that are active on gender-based violence and sexual violence in Borno State, as well as with the government. Can you elaborate also on what kind of follow-up will be given to this study now in Borno State, if possible, among these stakeholders, or what they have shared with you? I see in the meantime also still hands coming up, so we can take one other question as well by David. David, come in.
Maybe until David comes around, I can quickly talk about what we did in terms of follow-up already and what's next. So we already had a validation session with a validation and dissemination session with government stakeholders in Abuja, and another validation session which was also conducted online with key players working in the areas that we did the research in terms of how we can incorporate the recommendations, but also hearing from their perspective as practitioners what works and what doesn't. And Diana and Chitra, please come in if I have missed anything. In terms of what's next, we're also now in the process of course, disseminating the findings, where the webinar is one avenue for this. And we're keen to hear from participants of this webinar if how they would be taking up these recommendations and if this is relevant for your work, some of which has already been discussed in the chat, but also talking to the GBV subsector working group in the country to discuss what can come next, and having bilateral conversations with organizations working on this topic. So that's just to give you a taste of what's coming up next.
Thank you, Tasneem. So yes, having this webinar, we were also are very curious to hear from you. You have heard these findings. Half of you are working on gender-based violence directly. Others are working in other sectors. You are all, half of the participants are also active in Nigeria, it seems. So what can you do with these findings? Can you elaborate on that in the chat? To give you a couple of minutes for that, to reflect on that. As we want to, of course, have done this study to be useful and to make use of this evidence in the end to support the response to sexual violence survivors, but also to put much more effort in the prevention of sexual violence. But also with the humanitarian agencies more and more withdrawing, that there are also development responses coming in to adjust and change the situation and reduce the different varieties of sexual violence. So let's come in on the chat. You can write down what you could do with these findings, what you have just heard. Take a moment to reflect about it and write in the chat. Or if you want to come directly in, I see some more hands coming up, then you can also just speak out. Nogati, do you want to speak out on this question?
Yes, please. Can you hear my voice?
Yes.
Okay. Thank you for the great presentation and all the information. I want to ask about specifically on the less visible type of the sexual violence that's mentioned before. My question is how to address that less visible type of sexual violence, like the intimate partner violence, for example. And also, my next question is there any key informant interviews that share about the violence happen maybe during their pregnancy, for example? Thank you.
Okay, Nagati still had some questions, so let's take them. But in the meantime, I will also want to ask you as participants to write down what you think you will be able to do, or how to use these findings, or what kind of recommendations do you have to disseminate the information. So a question about less visible forms of sexual violence. Who would like to come in on that question from the team? How to respond to the less visible forms of violence, like intimate partner violence?
Diana, do you think this is something you could take up?
Okay, Shitra?
Yes, I'm happy to say something on this. I think it depends on what kind of violence you're talking about and what the social and cultural dynamics around that are. And so there would be, you would have a different approach, for example, dealing with female genital mutilation cutting, as opposed to intimate partner violence. And so for FGMC, for example, one of the things that I would say is to go to the communities in Borno State that practice this form of sexual violence, and really take a community-based approach, working with women in those communities, supporting them to reach people with influence, and taking a social norm-based approach to that. At the moment, there is very little to no work on FGMC in Borno State, and the only service provider who spoke with us about that talked about basically going into this community and stressing the health consequences of engaging in FGMC, which is fine, but I think you really need to, especially if it's a form of sexual violence that's practiced by one particular community, you need to take a much more community-based approach rather than someone from another ethnic group going into that community who works for government and telling them not to do this anymore. For IPV, this becomes difficult, especially because there is this idea that there is no rape within marriage in particular, because as soon as you're married, you're automatically assumed to consent to all forms of sexual activity that happen afterwards. However, when you talk to women, they're really unhappy about what they call forced sex. And in Borno State, there has been a real shift in people's gendered realities. Sorry, I'll just switch on my video for the last bit. There's been a real shift in people's gendered realities. And so what women are doing, what men are doing has changed. Women are so busy with so many responsibilities and tasks now. Meanwhile, men are not able to fulfill what are seen as traditional breadwinning responsibilities, which is one of the dynamics that play into what they call forced sex within marriage, because women say no and then the men do continue anyway, because the women don't necessarily see the men as fulfilling their role within the family, and also they're very tired and they don't want to engage in sex after a long, hard days. But despite all of these changes in gender dynamics, there isn't enough support for families and communities to adjust and discuss what this means for them. And so working on issues of intimate partner violence in Borno, for example, could mean looking at these wider dynamics and helping families, communities to adjust to these changes in gender dynamics, which is one of the causes of marital rape. It also means addressing the stigmatization around sex outside marriage, so that if sexual violence does occur, between a boyfriend and a girlfriend, for example, that girl or woman does not feel that she cannot tell people and cannot seek support. And so addressing issues around victim blaming and stigmatization are very key. And in terms of your question on violence in pregnancy, I was actually trying to think if it was mentioned by any of our respondents. The only thing that I can think of which comes close is one thing that one of our respondents said to us about the pressures around the particular gender of children. And so, for example, if a woman had delivered many daughters, there was pressure on her that the next child would be a son. And, you know, quite significant pressure. I think that's the only thing that I can think of, unless Diana, Tasneem, something comes to mind around pregnancy, but maybe, and also, sorry, in some cases as well, some dynamic around if a girl is pregnant outside of marriage, some pressure to abort that pregnancy. Unclear whether the girl in question wants that or not. I think those were the only two things that I can think of. But Diana, Tasneem, please add if anything else comes to mind.
Okay, thank you, Chitra, and for the audience as well, and all the other speakers for joining in and presenting the findings of the research. There are maybe several questions more that have been asked in the chat, and we will try to give follow-up to them by sending you an email on that. We have come to the end of this first webinar. We will have a few announcements left for you. First of all, to know that the full report with all the details will be available on the KIT website. Here is the link, Findings from Research on Sexual Violence in Humanitarian Settings. So we will upload the recording and also the full report on the study. This study in Borno State will be available on addressing sexual violence. The two other announcements that we have is that the study done in Nigeria is not the only study. We also have conducted research on sexual violence in the south of Yemen, with lots of challenges faced around the different forms of violence, the stigmatization and self-blaming that is also happening there a lot, but also with information on what kind of services were and are available among several health facilities in the south of Yemen. This presentation will be held on Tuesday, the 17th of May, on the same time. So that is, 2:30 Central European time. And you can still register. It's the same register system as you probably received the flyer from, but also above here in this link, you can also register for this webinar if you haven't done so already. And the third webinar will be about on the 24th of May, the same timing again as this afternoon or morning or evening, wherever you are on the planet, with lessons learned on sexual violence research in conflict settings in times of COVID-19. So this is specifically about general lessons learned that we have on conducting sexual violence studies. Yes, and we have come to the end, and I would thank you all for your participation, and once again for the research team for presenting the study findings, recommendations, and good practices. And I wish you, and also the translation team who helped with the translation, I would like to thank you, and the support team that are on the background helping with technical support and facilitation. So thank you all for joining, and have a good afternoon or evening or morning. Bye bye.